with absolute indication with absolute indication for surgery or non-responder to medical treatment, or those who do not want medical treatment but request selective treatment. If a patient is high risk, then if he can have surgery under anesthesia, if no, then prosthetic urethral lift offered to the patient. And if yes, then if he can stop anticoagulation or antiplatelet therapy, then we will see the prostate size. If it is less than 30 ml, then TUIP is the first preferred choice, then followed by TURP. Prostate volume is 30 to 80 ml, then TURP is the first procedure of choice. If the prostate size is more than 80 ml, then open prostatectomy, HOLAP, and bipolar enucleation and other methods are laser vaporization, thulium enucleation, and TURP can be done. Surgical procedures for the prostate surgical treatment is one of the cornerstone of LOTS and BPH management. It consists of resection, enucleation, vaporization, alternative ablative techniques, and non-ablative techniques. Resection of prostate in bothersome LOTS, transurethral resection of prostate is either performed in a monopolar TURP or bipolar TURP fashion. Monopolar TURP is the gold standard, but bipolar TURP have similar efficacy with monopolar TURP but lower perioperative morbidity. The minimal invasive techniques for BPH management is water vapor, thermal therapy, resume, aquablation of prostate, temporarily implanted nitinol device, urolift, prostate artery embolization. Other non-popular methods are intraprostatic stents, transurethral needle ablation of the prostate, transurethral microwave therapy, transurethral vaporization of the prostate, Botox injection, ethanol injection, Optilium BPH catheter system, X-flow expander system, Genflow spring system. The water vapor thermal therapy, popularly called resume, thermal ablative technique that achieves heat transfer via convection, office-based setting, and is typically done using oral sedation. Tissue necrosis at a lower temperature in a shorter amount of time. Key components of the system includes a radio frequency generator, a single-use transurethral delivery device with an integrated 30-degree cystoscopic lens for direct visualization, a retractable 18 gauge polyether ketone needle, and a saline flush. Technique, in the technique, it can be done in local block or sedation. The surgeon guides the delivery device into the prostatic urethra under direct cystoscopic visualization. The radio frequency generator converts sterile water into steam that is then delivered and injected into prostatic adenomatous tissue by the delivery device and PEEK needle. When the steam travels through the prostatic adenoma, it immediately phase shifts from vapor back to the liquid, releasing and transferring 208 calorie of thermal energy to the target tissue. This release of stored thermal energy causes irreversible cell membrane damage and cell death. The FDA approval to the resume is approved in 2015. Resume 2 trial completed in 2021, decrease in IPSS by 48%, 22 to 11.1, and decrease in IPSS quality of life by 45%, and increase in Qmax by 49%, 9.9 ml to 14 ml per second in the resume 2 trial. Medical retreatment rate of 11.1% and surgical retreatment rate of 4.4% with no erectile dysfunction or retrograde ejaculation in treatment arm. The most side effects seen was dysuria in 16.9% cases, hematuria, frequency or urgency, acute urinary retention, and suspected UTI, which were resolved within 30 days. This is the resume delivery device and a vapor needle. In aquablation, ultrasound guided surgical technique that uses a heat-free, high-velocity water jet. Three main components: the robotic handpiece, the surgeon console, and the conformal planning unit. General or it can be done in general or spinal anesthesia. The maximum angle of resection is 225 degree and the maximum cut depth is 25 mm. In a windshield viper motion, high velocity saline follows the outline field and resects the obstructing prostatic tissue while sparing the bladder neck and verumontanum. Average resection time was around 5 minutes. Hemostasis may be achieved through focal bladder neck cautery. FDA approved in 2017 water two trials were and non-inferior in efficacy, reduction in IPSS, superior in safety. The rate of anejoculation was lower after aquablation. No statistically significant difference in IPSS reduction, IPSS quality of life reduction, and Qmax increase across group or across time comparing aquablation with TURP. Aquablation is an effective surgical technique for larger prostate, more than 80 cc. The adverse effect seen is the risk of blood loss and possible transfusion. It is not an approved treatment of BPH for men on anticoagulation. Lacks a direct method of achieving post-resection hemostasis. This is the aquablation unit, CPU, and the handpiece. The next method is prostatic urethral lift. Prostatic urethral lift procedure involves delivery of implants that retracts obstructing prostate lobes using Urolift device. Mechanically opens prostatic urethra with Urolift implants that are placed transurethral under cystoscopic visualization, thereby separating the encroaching prostatic lobes. Does not appear to cause retrograde ejaculation, preserving erectile and ejaculatory function, and improves symptoms and voiding flow. Aim of urolift procedure to create an anterolateral channel from the bladder neck to the verumontanum. May be performed under local spinal and general anesthesia with or without additional sedation. Ability to perform procedure under local anesthesia may be advantageous for patients with significant multiple comorbidities. In patient selection for the urolift is ideal prostatic anatomy for a successful urolift procedure is where lateral lobe enlargement is responsible for bladder outlet obstruction. Bladder neck should be normal with minimal median lobe enlargement. Size of the prostate in selected patients should not more than 100 cc. May be ideal for younger sexually active men who request management of bothersome loads. Men who may not want to take lifelong medication, have failed medical management, or are averse to cavitating surgery. The Urolift system comprising nylon sutures and the suture delivery device. The delivery sequence of the Urolift, the device is introduced under cystoscopic guidance, and the lateral lobes are compressed by the device. Lateral lobes of the prostate are compressed by the device, and the needle is deployed. Additional sutures are delivered if needed to maintain and open the prostatic urethral lumen. Efficacy in improving symptom scores and quality of life in men with LUTS is proven. Not only are the clinical outcomes following a prostatic urethral lift immediate, but they have also demonstrated durability for up to 2 years. Since procedure does not affect integrity of the bladder neck, integrated and ejaculation is maintained, and in absence of thermal tissue damage, risk of erectile dysfunction is minimized. Adverse events are seen in dysuria, hematuria, and pelvic pain, with 36, 26, and 21% of patients affected respectively. The next method is temporarily implanted nitinol device. Temporarily implanted nitinol device that is deployed in the prostatic urethra and bladder neck. Three elongated device consists of 3 elongated nitinol struts connected at the distal end, an anti-migration anchoring leaflet, and a polyester retrieval suture. Using a cystoscope, the device is deployed and retracted so that the anchoring leaflet is under the bladder neck at the 6 o'clock position, and the 3 struts are in 12, 5, and 7 o'clock position within the prostatic urethra. Once inserted, the bladder is drained and the patient is discharged with simple analgesics. The total procedure time is less than 10 minutes, and the most cases are done in the office-based setting using local anesthesia. Expands and reshapes the bladder neck and prostatic urethra, creating an open channel. After a week, the device removed by using the retrieval suture and a special open-ended silicone catheter. Catheterization is not necessary after placement and after removal of the device. Patients are discharged on the same day. This is the nitinol device with the intertwined nitinol struts and anti-migration anchoring leaflets. This is approved by FDA in 2020. There was a 40% reduction in the IPSS at 3 months that sustained through 12 months. Similar improvements were seen in IPSS quality at 3 months and 12 months, as well as in QMAX at 3 months. Not reported de novo retrograde ejaculation or erectile dysfunction. Retreatment rate within 1 year was 4.7%. Minor self-limiting complications. Common complications include transient hematuria, urgency, and dysuria. These are the comparison between these 4 popular procedures: aquablation, resume lift, and ITIND. The aquablation done for the prostate size more than can be done with 30 to 150 cc of prostate, and the side effects are seen with anejaculation, and resume are done for 30 to 80 medium size prostate, and minimal erectile dysfunction and retrograde ejaculation are seen. Urolift approved done in up to 100 cc of prostate, and ITIND done for smaller size prostate, small to medium size prostate. The next method is prostate artery embolization. It is discovered by 1917 by Lange et al. As a treatment option in intractable prostatogenic hemorrhage. A multidisciplinary team that includes a urologist and an interventional radiologist. Indications are symptomatic BPH refractory to medical treatment. Potential benefit of prostate artery embolization over surgery: reduced morbidity and avoidance of a general anesthesia. Usually performed under local anesthesia and sedation. The aim of prostate artery embolization for BPH is to reduce blood supply of prostate glands, causing some of it to undergo necrosis and subsequent shrinkage. Using a percutaneous transfemoral approach, super-selective catheterization of small prostatic arteries is done using microcatheters. Embolization involves introduction of microparticles to block these small prostatic arteries. Embolization agents: polyvinyl alcohol, gelatin sponge. Current evidence on the safety and efficacy of prostate artery embolization for BPH is inadequate in quantity and quality. Complication of prostate artery embolization is theoretical adverse event as inadvertent embolization and subsequent infarction of adjacent organs such as bladder and possibly rectum. Damage to cavernosal artery and erectile dysfunction. Damage to external urethral sphincter and incontinence. Arterial pseudoaneurysm, urinary fistula, prostatic abscess, hematoma, dysuria, and worsening BPH symptoms. The next method is intraprostatic stents. Requires a functioning detrusor so that bladder still has the ability to empty itself. Alternative to an indwelling catheter in unfit patients. There are 2 types of stents: temporary and permanent one. Temporary permanent stents biocompatible, allowing epithelialization so that eventually they become embedded in the urethra. In temporary stents, neither become covered by the urethral epithelium nor become incorporated into the urethral wall, made of either a non-absorbable or biodegradable material. Non-absorbable stents need to be removed every 6 to 36 months. The indication of temporary stents, the alternative to catheterization for elderly and frail patients unfit for surgery. Temporary retention that can occur secondary to treatment such as laser therapy, high energy, TUMT and TUNA. Permanent stents, recurrent urethral strictures, detrusor sphincter dyssynergia, advanced prostate cancer with bladder outlet obstruction who are frail or unfit for surgery. Post brachytherapy, bladder outlet obstruction, anastomotic stricture, and urinary incontinence after radical prostatectomy. Complex urethral strictures. Contraindication for stenting is detrusor failure, untreated urethral stricture, difficulty in insertion of previous TURP, a coexistent bladder cancer, patient who need endoscopic treatment to their upper tract due to coexistent pathology. Transurethral needle ablation. TUNA uses low-level radiofrequency energy that is delivered by needles into the prostate. Coagulative necrotic lesion in the hyperplastic tissue consists of special catheter attached to a generator. At the end of the catheter are 2 adjustable needles that are withdrawn into the 2 adjustable shields made from Teflon. The generator produces a monopolar radiofrequency signal of 490 kHz, excellent penetration and uniform tissue distribution. Radio frequency power that is delivered to 2 to 15 watt for 5 minutes per lesion. Temperature at the tip of needle 80 to 100 degrees centigrade. Urethral temperature is kept below 46 degree. Thermal lesion may extend for up to 5 to 6 mm beyond position of needle deployment, and with lesion measuring up to 20 to 10 mm. Number of lesion depends on size of prostate. One pair of lesions should be used to treat 20 gram of prostatic tissue. Venous system can create a 1 centimeter necrotic lesion without difficulty in prostate with no damage to rectum, bladder base, or distal prostatic urethra. Configuration of the needles assures prostatic urethra is spared. Topical anesthesia can be used with patient experiencing only moderate discomfort. Post-procedural irritative urinary symptoms are kept to a minimum. Difference in method of tissue hitting brought about by radio frequency and, for example, microwave application. Microwave treat a broad area and can penetrate tissue more deeply than radio frequency. The central temperature is therefore lower than the radio frequency to maintain safe heat level at the treatment rim. Therefore, treatment with microwave takes longer than the radio frequency to produce coagulative necrosis. The most up-to-date version of tuner catheter is called the Provo system, and part of this device is reusable, unlike previous models. This is the Provo device for tune of prostate. Indication: men within 70 years of age, prostatic volume is less than 60 cc, pre-treatment, detrusor pressure less than 50 centimeter H2O, residual volume of less than 100 ml. Fewer adverse event compared with URP, including mild hematuria, urinary discomfort, infection, stricture, incontinence, erectile dysfunction, and ejaculation disorder. Contraindications are active UTI, neurogenic, decompensated, or atonic bladder, urethral stricture or muscle spasm that prevents insertion of sheath, bleeding disorders, clinical or histological evidence of prostate cancer or bladder cancer, prostate, smaller prostate, and more than 80 cc of prostate, presence of cardiac pacemaker, implantable defibrillator, or malleable Nile implants. The next method is transurethral microwave therapy. Microwave radiation through an intraurethral antenna in order to deliver heat into the prostate. Tissue is destroyed by being heated at the temperature above cytotoxic threshold, more than 45 degrees centigrade. It causes coagulation necrosis. Heat is mainly produced by electrical dipoles, water molecules oscillating in the microwave field, and electric charge carriers moving back and forth in the microwave field, causes apoptosis and denervation of the alpha receptor, thereby decreasing the smooth muscle tone of the prostatic urethra. Involves insertion of a specially designed tube-type urethral catheter into bladder, allowing a microwave antenna to be properly positioned within the prostatic fossa. Disposable treatment catheter contains microwave antenna closed with closed water cooling circuit and retention balloon, performed on outpatient basis and usually take 30 to 60 minutes. Two most common used TUMT devices are Prostatron and Targis. This is the Prostatron device. The drawback is no tissue is available for pathology, and contraindications are patients with penile implants, metallic implants in region of hip or pelvis, urethral stricture disease, peripheral arterial disease. Patient received radiation therapy to pelvic area. Ball wall median lobe does not respond to TMT and is contraindicated in the median lobe enlargement. Next method is intraprostatic ethanol injections. Absolute ethanol 95 to 98% injected into prostatic parenchyma for treatment of blood secondary to BPH. Precise mechanism of action in both human is unclear. Inflamed coagulative necrosis with protein denaturation and cell membrane lysis, and atrophy and ablation of prostatic tissue resulting in cavity formation. Intraprostatic cavity formation appeared in model after 7 days. Transurethral transrectally under ultrasound guidance. Specific device for transurethral device delivery of ethanol. No concession on the number of injection sites or injection volumes. Can be done in local, regional, or general anesthesia. Procedure is usually completed within approximately 30 minutes. And most patients in dwelling catheter after procedure because it takes 7 days to. Best. After an initial strong reduction in prostate volume, prostate size had increased again after 1 to 2 years postoperatively. Although loads and Qmax remained significantly improved, retreatment rate is 41% at 3 years, and frequently reported adverse events are perineal and abdominal discomfort, bladder storage symptoms, and hematuria, UTI, or epididymitis, and urinary retention. Intraprostatic botulinum toxin injections. It is a exotoxin of the bacteria Clostridium botulinum. It has A2G strands and Botox A used for intraprostatic injection for treatment of LUTS and BPH. A neurotoxin induced denervation atrophy, reduction of apoptosis, induction of apoptosis via blockage of acetylcholine, inhibition of proliferation and downregulation of alpha-1 adrenergic receptor in the prostate may contribute to the smooth muscle cell relaxation. Under ultrasound visualization, Botox A injection into prostatic parenchyma transperineally, transurethally, or transrectally using a 21 to 23 gauge needle. The size of the prostate determines the units are injected. 100 units for less than 30 cc prostate, and 200 for 30 to 60 cc, and 300 units for more than 60 cc prostate. Most patients are treated without anesthesia, local anesthesia, or sedation. Prostate volume seemed to increase again after 6 to 12 months, despite a stable improvement in symptoms. A retreatment rate of Botox were as high as 29%. Main reported complications are dysuria, hematuria, epididymitis, and prostatitis. The next method is transurethral vaporization of the prostate. With UVP, two surgical effects are combined: vaporization and desiccation. Vaporization steams tissue away using high heat, more than 300 degrees centigrade, and coagulation uses lower heat, less than 60 degrees, to dry out tissue. Vaporization occurs at the leading edge, and desiccation occur at the trailing edge of the electrodes. For TUV, the cutting current power should be set to a maximum of 75% of higher power than for a standard TURP, but the power used need not always be as high as this. In fact, it has been estimated that a minimal power delivery of 150 watt is required for the TUVP. The two types of electrode designs are there. Roller ball can be used for TUP. However, it should not be used for prostate that are particularly large. It cannot be used for larger prostate. And a grooved roller ball widely used for consists of a bar that is 3 mm wide and 3 mm in diameter, which is composed of nickel silver and insulated with the Teflon. Efficacy appears similar to that of TURP, but study a short-term complication profile appears to be better than TURP, but in general, although the catheterization time is shorter than with TURP, the operating time is longer. Retrograde ejaculation were lower in the TUVP group than TURP. The Optilium BPH catheter system, it is a mechanical solution, balloon dilatation of the prostate. There also delivers a localized anti-proliferative drug to achieve an immediate and long-term urethral patency. Two balloon catheters, a pre-dilation balloon and a drug-coated balloon. Anti-proliferative drug paclitaxel delivered at the level of external urethral sphincter or prostatic urethra. Adverse events, most common complication post-treatment urinary retention, and second most common irritative loads, irritative voiding symptoms. Advantage are short stay and outpatient procedure. Disadvantage is no tissues available for pathology. X-flow expander system technique. Mechanical solution for BPH. The X-flow system consists of a reversible nitinol tissue expander that is delivered to the prostatic urethra using a standard flexible cystoscope. The device is left inside the prostatic urethra in an office setting. Exact device specification, technique details, and implant duration are still in development phase. The expander 1 study is ongoing, and 40% reduction in IPSR at 2 weeks that appeared durable through 6 months.
Can I ask?
Yes.
Go back, please.
Yes.
So the tuna has significant higher retreatment rate compared to TUR.
Sir.
When you are explaining about Optilium, then how does tuna
Yes,
come inside this slide?
सर वो गलती से
आप तो Optilium
Yes.
बता रहे हो ना, तो tuna का कैसे आ रहा है?
That's not. This
The Genflow spring system, it is a nitinol implant and delivered through a proprietary flexible cystoscope to the prosthetic urethra. Like the X-flow system, the spring is designed to be a permanent device that is embedded into the wall of the prosthetic urethra through internal tension.
So, thank you, Keshav. And I think, yes, we have, if anybody, resident or faculty has any suggestion to make or any query, they are most invited. And you can just raise your hands also if you want, those who have joined us on Zoom. So again, we have interesting topic and a controversial topic also. Nachiket will agree with me. We have discussed, because this has been discussed in so many conferences and workshops. And there were, I think still, because these minimally invasive surgical techniques do not have a very strong evidence as such. So still, they cannot be recommended as a evidence-based, because they require longer follow-up, long-term studies, longer, greater population study, and before they can be recommended as a appropriate treatment. So we all know the update on the management of BPH. There are a lot of changes. As we were discussing, this minimally invasive therapy of ethanol injection that started somewhere in the 1960s from somebody from India only in Ajmer, Dr. Talwar. And then it has come back again after maybe how many? 80 years? 80 years. So this is the whole circle, which usually happens in many of the management therapies. We all know in 1970s, the QRP, transurethral resection, became very popular. And 80s, it was the commonest, second commonest operation being performed in the world, you know. So the first operation was the cataract surgery and followed by QRP. It was that common in 1980s. And then definitely the medical management came, and we all know now it has taken, not all patients, majority would be responsive to medical management, and few would require a surgical therapy. We all know the various indications of surgical management. Those who are refractory to medical therapy do not want to take, or if there are complications. When we talk about minimally invasive therapies, they are recommended only in cases where we cannot do standard procedure in the form of either TURP or monopolar or bipolar, or an enucleation of the prostate, which could be HOLEP or PULEP, or even a bipolar enucleation, because the patient cannot be put under general anesthesia or spinal anesthesia. So those patients where we want to do something for the patient and do not want to keep him on prolonged catheterization, this minimally invasive surgical technique come in use, because they can be done under local anesthesia and sedation. So when we talk about this minimally invasive surgical technique, aquablation or the robotic water jet therapy is not considered as a minimally invasive technique, because it has to be done under general anesthesia or spinal anesthesia. So you should not include aquablation. People have included, but aquablation should not be included under the minimally invasive surgical techniques if we take the definition as they have to be done under local anesthesia or sedation. The other techniques, the most two popular techniques now, recent, is the resume and Eurolift. So resume is coming up in a big way, and what we know is water vapor therapy, and Eurolift is kind of nitinol anchors which are put in the prostatic tissue. The anchor goes behind the capsule and it just presses the whole prostatic tissue and creates a space for flow, urinary flow. So this is how, but again, the major disadvantage of Eurolift is that if there's a large median lobe, it will not help, right? So median lobe is again a relative contraindication for a Eurolift. when we talk about these minimally invasive surgical techniques, majority of the companies or the people who are propagating it, they say that sexual function is an important concern in many of these patients. And because this doesn't produce sexual dysfunction, this is one of the better option. But I partially disagree with it, because this is more of a kind of a promoting kind of a thing which they are trying to say. As when we talk about ejaculatory dysfunction, we must know that there are two phenomena. One is ejaculation and one is orgasm. So if the ejaculation is absent, that doesn't mean the orgasm is absent. And what a 60-year-old man is interested in? Is he interested in ejaculation or orgasm? Yes? Yes, orgasm. What he wants to know, have the sexual pleasure, and not fertility is not an issue, right? So again, this kind of a propaganda that sexual dysfunction is happening in majority of the patients is not probably very correct. Though yes, some patients do think that they need to have ejaculation, but again, they have to be convinced that you will have orgasm even if you are losing ejaculation. So many of these patients will have orgasm. So these were a few points on the minimally invasive techniques. And I think, again, when you talk about invasive therapies, these are very costly devices, right? And then if we still don't know the exact outcome of these patients, so why not do those minimally invasive techniques which are available to us, like TUIP in a smaller prostate? If there's a 40-45 gram prostate or less than that, you can do TUIP. Why don't you do just a median lobe resection sometimes, and which can be done sometimes under local anesthesia or sedation, or intraprostatic injection of Botox or alcohol. There's nothing. You need the same system, the needle you usually have in the OT, and just put Botox or alcohol and try to see whether these patients can be helped. I think we need to think over it before we actually start doing these other minimally invasive techniques. So if anybody has anything to say, we will take up those questions. Otherwise, we will go ahead with the MCQs. So this was the last slide. Which was the slide? This one. Right. So for the benefit of the residents, a few MCQs. Question number 1, when using the prostate lift for treatments of low unit tract symptoms due to BPH, implants are placed where in the prostate anatomically? Anterolaterally, posterolaterally, anteriorly, posteriorly, in the peripheral zone?
Anterolaterally.
Anterolaterally, okay. So answer is, you didn't say the answer. What is the answer? Anterolaterally, yes. You should have given the answer also. Okay. Aquablation therapy is particularly suited for patients with smaller prostate, prostate with calcification, very large prostate, prostate cancer.
Small prostates.
No. So aquablation is a robotic water jet therapy. It can be used for larger prostates also. This is one of the advantages. But again, this is not as I said, it should be done under GA or a spinal anesthesia. So this is prostate with large prostates, very large prostates. And this is anterolaterally, as the answer was. What is the primary mechanism of Urolift system in treating BPH? Vaporizes prostate tissue, uses heat, lifts and holds the prostate tissue away from the urethra, shrinks the prostate by arterial embolization. So very, very simple. It lifts and holds the prostate tissue away from the, so there is a nitinol anchor, which is just put through the prostatic tissue outside the capsule, and that anchors the prostatic tissue and compresses the prostatic tissue, thus producing space for voiding. So what is a common side effect immediately following resume therapy? Persistent erectile dysfunction, severe bleeding, urinary retention for a short period, permanent incontinence. C, urinary retention. So usually these patients would require a longer catheterization, sometimes even for 2 weeks. So minimum 7 days and maybe 2 weeks. So that is why that is a very common side effect of resume. So resume therapy is most effective for which of the following prostate sizes? Very large prostate, small to moderate size prostate, extremely small prostate, only prostate with significant calcification. So small to moderate size. So that is again for larger prostates, still resume therapy is not very useful, though people have done till 150 grams. But in majority cases, it is useful between 30 to 80 grams. The iTind device primarily works by ablating prostate tissue, vaporizing prostate, remodeling the prostate urethra through the mechanical pressure, and freezing prostate tissue to shrink it. See, so remodelings. What the majority of the other stents, they used to just kind of compress the prostatic tissue and create a wider urethra. But this is something like they have struts, and they have a kind of a device which is put at the 6 o'clock positions and the strut at 5, 7, and 12 o'clock positions, so that it just widens the bladder neck, right? So this is a temporary device which can be removed, because majority of the stents had complications like migration or encrustation, where the removal of the stents was very difficult, which is not the case here with iTind. So iTind is a temporary device. If you want to buy time before you go ahead with the definitive treatment, this is probably one of the optimum therapy. Which of the following patients might not be suitable for prostatic artery embolization? Patients on long-term anticoagulation, patients with poor vascular access, patients with larger prostate, patients looking to preserve sexual function.
Patients looking to preserve sexual function.
So yes, sexual function. This is, I think, B and D both probably appears, because if they have a poor vascular access, how will you do the embolization? Okay, so and sexual function is also deranged in artery embolization, because the cavernosal artery, etc., everything gets blocked. So erectile dysfunction is a very, very common side effect. So he has answered vascular access, but the D is also right. I think, thank you. Yes. So anybody has any query? Residents, the Dr. Naji, anything you
Yeah, I
want to say?
wanted to ask him, because you have told so many things.
You can
inside
come
the-
here, let us.
inside-
Okay.
You have told so many things. So presently, what do you think in the future might be placed for in a medium-sized lens? What would be the thing which will come clinically used by everyone?
You can come here and just come here, come here. So the question was by Dr. Nachiket was, what does he think after reading through these minimally invasive surgical techniques could replace the gold standard TURP or HOLEP TULEP, right? Do you have any idea?
सर वैसे तो ये एज वाइज अलग अलग होगा कि अगर मान लो ओल्ड एज में अगर कर रहे हैं तो सर जैसे जो न्यूअर डिवाइसेस हैं केबल की जो केवल स्क्रू वाली जो एक्सफ्लो वगैरह है वो भी बेटर रहेंगे उसके लिए कि जिनके लिए केवल
No, so Keshav,
and
yes,
एक्वाइब्रेशन
no. I think still we are not very clear on that, whether they can replace TURP or the HOLEP or TULEP.
We wanted to listen to his opinion.
No. So we have. I could understand what he was saying as he started saying. So he's not very clear. At least we are not clear. So how can we think that he will be clear on this thing? We may ask something which probably he understands or knows, right? We also don't know whether something can become or replace TURP. So at present, the evidence is not very strong to replace TURP amongst any minimally invasive surgical technique. Right? Anybody?
Sir,
Yes, Prashant, yes.
Give two comments
Yes.
regarding the seminar.
Hmm.
No question, only comments. Number one, if you are going to tell the latest techniques, then you should mention this technique when it was invented and given by who. It is a very important thing. And number two, at the end of the technique, you should mention the supporting evidence which RCT literature has been published regarding this technique. If you have shown ethanol injection was absolute long before. Even in 2000, you are showing the latest technique of BPH management.
Yeah, I'll tell you something about this.
Yeah, Nachiket.
Sir, I don't.
Okay, come.
See, ethanol injection,
Yeah.
even though the preliminary study on canine model about ethanol injection was done in 1960, surprisingly by Dr. Talwar, the same Dr. Talwar who gave the Talwar's modification for Baranox procedure. But it was picked up by Boston Scientific, and recently they are still using therapy by the name of Prostaject. And a Prostaject aata hai, and the basis of Prostaject was by the study of Dr. Talwar. So it is still being used. So it is still being. Yes, it is. Unfortunately, Dr. Talwar never got the credit for his work that he had done on quinine model. And it was only when it was discussed inside urology, meetings in India, that ultimately when the data was projected that this was done in 1960, then ultimately it started coming inside books that this was done. So Prostaject, which has been picked up by Boston Scientific after 40 years, the starting was done by Dr. Talwar. So this is something that we should be proud of.
You are right. You are right. So the 2 points that were raised by Dr. Prashant was that whenever we are presenting, we should have a little interest in who developed this, right? So we can always write down who was the inventor of that particular device. So that makes the presentation a little more interesting. Secondly, from the evidence based evidence, we need to put some kind of a footnote on which publication or which journal published the first study on that particular device, and whether it was a randomized control device, so that we know exactly whether this how strong the evidence is, right? So when we are talking about scientific evidence, because in nowadays we do not just have a kind of anecdotal kind of pictures, right? We need to have a strong evidence. So you need to write the studies which have been done on that particular device. So those 2 points. The third point which Prashant made was the alcohol injection, which he says that is obsolete. Dr. Nachiket gave the correct argument that yes, it's not obsolete. Even the Boston Scientific developed recently that prostatic alcohol injection by way of Prostaject, which was actually first propagated by Dr. Talwar in Ajmer way back in 1960s. So that's a very important point that has been made. Anybody has any other? So if nobody has anything else to say, I would request Dr. Kuldeep to kindly.
Prashant has made a very important point, sir. This is because all these trials now, it's important that he should name the trial which ultimately led to clinical use.
Right.
What important?
Very important, because there are 2 or 3 devices, they have already been approved by FDA, and that is always done after a proper study, randomized controlled study, which is usually done. So I would request the moderator to kindly just give his last comments, and then we will wrap up the session. Yes, thank you.
This is Eurolift, sir. The Canadian Neurological Association has not given approved Eurolift. So Canadians actually come down to America to get the Eurolift done. And ये FDA तो क्या है कि money minting machine है ना sir. So they are just concerned about पैसा तो
आपस में कोई है कैनेडियन और दोनों में आपस में
ये level of evidence माने नहीं है Canadians ने. They have not approved the level of evidence.
Okay, go ahead.
Thank you, Keshav, and special thanks to our HOD, Dr. Shivam sir. Today we discussed the different modalities on minimal invasive modalities for BPH and many arguments, and finally we conclude with today's discussion that no clear-cut evidence and no procedure, any procedure which is we can proceed or replace the QRP. Thank you so much. Thank you, sir.
Thank you. Only thing is, don't say TURP, because TURP, we have a HOLEP, TULEP, which is equally kind of now becoming the gold standard. So we have procedures which are there and have strong evidence. So these minimally invasive techniques definitely will require some time to become, if they get recommended by the strong based evidence. So thank you once again, everybody, and I wish all of you a happy Dashara and a happy Diwali. Thank you for joining us.